Muchas gracias, Pablo, por la presentación. Vamos a avanzar con la siguiente presentación, que está a cargo del Dr. Friedemann Paul. En la próxima presentación vamos a discutir aspectos de la resonancia y la OCT en el diagnóstico y en el seguimiento de los pacientes con enfermedad del espectro NMO y la patología asociada a anticuerpos anti-MOG. El doctor Paul es profesor de neuroinmunología clínica y vicedecano de la Universidad de Investigación de la Charité en Berlín. Adelante, profesor.
Dear colleagues, it's a great pleasure to present some new data on MRI and OCT and NMOSD and MOGAD to you. We are speaking about neuromyelitis optica spectrum disorders, a severe inflammatory condition of the central nervous system with severe attacks of optic neuritis, longitudinal extensive transverse myelitis, and area postrema lesions that are characterized by autoantibodies to aquaporin 4. We have now seen that a subgroup of patients with an NMOSD phenotype who is negative for the aquaporin 4 antibody tests positive for antibodies to MOG, myelin oligodendrocyte glycoprotein. And for this condition, now called MOGAD, new diagnostic criteria have been published a few months ago. And this is a disease that should no longer be diagnosed as seronegative NMOSD, but as MOGAD. You can see the key criteria here without going into detail. It's important that in some circumstances, you need additional MRI features to make the diagnosis, and I'll briefly walk you through these features in the next couple of slides. But to take a step back and go back to the 2015 IPND criteria for NMOSD. From this paper, you can see characteristic MRI features of NMOSD, for example, this LETM, this long cord lesion here, or some of the brain lesions around the ventricles or tumefactive lesions here, and the characteristic dorsal medulla area postrema lesions shown here. However, the majority of NMOSD patients does not have these characteristic lesions, but has so-called unspecific lesions. These are non-specific, usually very small, below 3 millimeter dots or patches of hyperintensities on T2 or flare-weighted sequences that are not necessarily related to NMOSD as a condition, but could also be related to age or vascular comorbidities, and these are usually asymptomatic. Now, we often have the issue of discriminating NMOSD and MOGAD, and now we have seen that the so-called central vein sign can be used to differentiate NMOSD and MOGAD, and you can see a characteristic example here. On the right side, you see an MS patient with an overlay of a flare sequence and a SWI EPI sequence. And you can see here a typical MS lesion with the central vein inside it. And when you look at the left side, you can see NMOSD lesions here without this characteristic central vein. And in a large study that was done with the Magnums group, you can see the numbers down here. You can use this criterion with a relatively good specificity. Sensitivity could be better to discriminate NMOSD from MOGAD. Another characteristic finding is shown here. This is the so-called bright spotty lesions on spinal cord MRI, highly characteristic of NMOSD. And many of these MRI features also appear in the diagnostic criteria published by the IPND panel in 2015. And this is important to adjudicate or to kind of positively diagnose NMOSD, but this is also relevant to address certain red flags. So lesions on MRI or MRI features that would rather argue in favor of another diagnosis, for example, such as multiple sclerosis. What makes the situation a bit complicated is the fact that a relevant subgroup of patients with both NMOSD and MOGAD fulfill the Barkov criteria for multiple sclerosis. So, which means that once you have an MRI that is suggestive of MS, this does not necessarily rule out a diagnosis of MOGAD or NMOSD. Now I'll move on to a few characteristic and discriminatory features that may help distinguish NMOSD from MOGAD. First of all, let's start with optic nerve imaging. It is very characteristic, as shown here, in the right upper part of the slide that MOGAD patients typically exhibit this papilledema or a swelling of the optic nerve head. This is also visible here on MRI of the orbiter. And when you look here at the left part of the slide, you can see that both conditions, MOGAD and aquaporin 4 NMOSD, have frequently bilateral involvement. But as shown here in C, it's usually the MOGAD patients who have this very profound optic nerve head swelling, whereas in contrast, as shown here in D, it is the aquaporin 4 antibody positive NMOSD that have chiasmal involvement. And intracranial involvement is also something more frequent in aquaporin 4 NMOSD. You can see a few more examples here. Contrast enhancement and here this chiasmal or the more the more posterior part of the optic nerves affected by NMOSD. Now let's move on to the spinal cord. There are also some characteristic features described for the three conditions, MOGAD, aquaporin 4 NMOSD, and multiple sclerosis. And you know that both conditions, MOGAD and aquaporin 4 disease, may have these long cord lesions. This is something very unspecific or very, very rare, in multiple sclerosis. And in MOGAD, you have this H sign, which you can see here. Something very characteristic for the condition. In aquaporin 4 disease, you have this more centrally localized necrotic area of the cord, and in MS you have a more peripheral or laterally located kind of wedge-shaped lesion appearance. Now, there are some very recent works on imaging in these conditions. This came out just a few weeks ago. This is on cerebral enhancement in MOG antibody-associated disease by the Mayo Group. And you can see a few examples here. This is MOGAD up here. This is aquaporin 4 disease, and this is multiple sclerosis. And in MOGAD, there is relatively patchy, unspecific contrast enhancement in a relatively high proportion of attacks or of patients or of scans, whatever you want. And you can see this down here. So enhancement is common with MOGAD. Cerebral attacks often has a non-patchy appearance and rarely persists beyond 3 months. And this favors MOGAD over aquaporin 4 NMOSD and multiple sclerosis. So it's especially the leptomeningeal enhancement that seems to be characteristic for MOGAD in contrast to aquaporin 4 NMOSD and multiple sclerosis. And now, to move on to the clinical management of patients, there still is a controversy as to whether regular MRI monitoring in these conditions is warranted. It's of course also a time and a cost issue. We know that we do this in multiple sclerosis, even in the absence of clinical attacks. However, is this really something that should be done in NMOSD and MOGAD? And there was a controversy in the MSJ 2 years ago, and also colleagues here from Latin America, from Argentina, contributed to this. And the key question in the end then is, how frequent is subclinical MRI activity? And if there is subclinical MRI activity, would this inform treatment decisions? Or in other words, would we switch or change immunotherapy if an NMOSD or MOGAD patient has new lesions without clinically overt attacks? And there is very little data on this, and I'll briefly walk you through what is known to date. This is one study from Korea published a few years ago, and the authors here found a low frequency of asymptomatic new lesions in NMOSD. You can see a few examples here on the right side, and the frequency was below 5%. All these lesions were smaller than 6 millimeters, were considered unspecific. So again, it's unclear whether they are truly related to NMOSD. There were no GAD-enhancing lesions, no NMOSD-specific lesions, and this was a cohort of more than 140 patients, so quite an impressive sample size. And something similar was published recently by the Mayo Clinic in MOGAD. Again here, they found a low frequency of asymptomatic new lesions in MOGAD. Again, you can see a few examples here. This was also below 10%. So as in NMOSD, the proportion of patients with new asymptomatic lesions seems to be quite low in contrast to multiple sclerosis. So again, this raises the question, does it really make sense to perform once per year an MRI or once every other year an MRI in NMOSD and MOGAD patients who are otherwise clinically stable? Now let's move on to optical coherence tomography, another emerging imaging tool that has been widely investigated in a research framework in NMOSD and MOGAD. Just to remind you, we see the various layers of the retina here in high resolution, and what is of utmost interest is the RNFL, the retinal nerve fiber layer, and the ganglion cell layer here. And that's why we typically use these two scans, the ring scan around the optic nerve head to measure the retinal nerve fiber layer, and the macular scan around the macula or in the region of the macula that is especially valuable for data on the ganglion cell and inner plexiform layer thickness. And now when we compare retinal damage in aquaporin 4 NMOSD and MOGAD, we can see that in both conditions, the amount of retinal damage seems to be comparable. This here on the left side shows the peripapillary retinal nerve fiber layer. The right graph shows the ganglion cell inner plexiform layers. You see there is no difference here, but a strong difference from healthy controls. However, in MOGAD, this damage is driven by a higher frequency of optic neuritis attacks in contrast to aquaporin 4 NMOSD. Which means, in other words, that a single attack of optic neuritis causes more damage in NMOSD than in MOGAD. And what is also striking is a strong structure-function disconnect in MOGAD ON that is not visible in aquaporin 4 ON and multiple sclerosis ON. And I'll briefly explain you what this means. You can see on this graph here on the x-axis, the ganglion cell inner plexiform layer thickness. On the y-axis, you see the high contrast letter acuity for the three conditions, MOGAD, multiple sclerosis, aquaporin 4 NMOSD or ON. And you can see that here, especially for aquaporin 4 disease, there's a very strong correlation between the ganglion cell layer thickness and the high contrast letter acuity, whereas this is not the case in MOGAD, as shown up here, which means that despite comparable loss of retinal tissue or loss of retinal ganglion cells in MOGAD, these patients seem to be able to better preserve their visual acuity in contrast to aquaporin 4 disease and multiple sclerosis for whatever reason. And the strong retinal damage caused by one single attack of optic neuritis is displayed here. This is the Croctino study, the largest, to date largest international study on OCT and NMOSD and MOGAD. Several hundreds of patients were enrolled, and you can see here that a first or one attack of optic neuritis causes a significant thinning of the retina, significant loss of retinal ganglion cells, and subsequent attacks of optic neuritis add little to this. And this again underscores the necessity for a timely and efficacious immunotherapy, especially in aquaporin 4 NMOSD, to prevent retinal damage and vision loss. Now, what about longitudinal retinal thinning in aquaporin 4 disease? This is a study we did together with colleagues from Oxford, from the UK, and you can see here that in contrast to healthy controls, there is some GCIPL loss over time. This is statistically significant, although the order of magnitude is quite small. Whether this is clinically relevant remains to be investigated. Now, for MOGAD, there does not seem to be a kind of regular loss of retinal tissue outside acute attacks in this condition, in contrast to aquaporin 4 disease. However, in MOGAD, there are characteristic findings on OCT. I showed you the fundoscopic and the MRI images of MOGAD patients, and this is also reflected through the OCT. You can see the SLO image of the OCT. You see a massive swelling of the PRNFL, and this is in stark contrast to multiple sclerosis. in acute optic neuritis. This is shown on the right. On the left side, you see a MOGAD patient here with the affected eye. And when you plot this, you can see that there is a massive increase in RNFL thickness in acute attacks of optic neuritis in MOGAD. That does not hold true in multiple sclerosis. And this is not the case in the ganglion cell layer thickness. So you can use the RNFL thickness to discriminate between MS and MOGAD. Why is this clinically relevant? You could argue there's the antibody, yes, but in many countries and situations, you do not have the antibody test available, or you have only poor antibody tests available, such as ELISAs, or it takes weeks before you get the antibody test back. And in such circumstances, it might be very valuable to perform an OCT to help with differential diagnosis. Now, to sum this up, MRI of the brain, optic nerve, and spinal cord is of paramount importance for diagnosis and differential diagnosis of NMOSD and MOGAD at disease onset. There are characteristic discriminative features of MOGAD versus NMOSD that are beginning to emerge. For example, the H sign in the spinal cord, the higher frequency of especially leptomeningeal contrast enhancement in MOGAD, etc. Asymptomatic lesions in the absence of attacks seem to be rare in both NMOSD and MOGAD, and there still is a controversy as to whether regular MRI follow-ups should be performed in asymptomatic patients. The OCT shows prominent structure-function disconnect in MOGAD in contrast to NMOSD and MS. And during the acute situation, acute ON OCT may help discriminate MOGAD from multiple sclerosis. In the future, we need a better and prospective imaging studies to understand whether perhaps in the future we will have to perform regular MRI and or OCT follow-up scans in these patients. Thank you very much, and then happy to take questions.